Hello, everyone. I'm Suzanne Toppy, Editorial Director at Springer Publishing Company. Welcome to today's webinar, Integrating Case Studies into Your Online and In-Person Courses. Our lead speaker today is Dr. Sam Wijesinghe, editor of our forthcoming text, 101 Primary Care Case Studies, a workbook for clinical and bedside skills. Joining Dr. Wijesinghe today are co-speakers and contributing authors to the book, Drs. Harry Kwan, Susan Layla Shore, and David Malebranche. Dr. Sam Wijesinghe is a principal faculty member in Stanford School of Medicine's PA program. He practices primary care medicine and HIV medicine at Adventist Health Central Valley Network in California. Dr. Harry Kwan is the Director of Professional Practice and Nursing Excellence and a nurse practitioner at Russian River Health Center in Northern California. Dr. Susan Layla Shore is a professor in the PA program at the George Washington University School of Medicine and Health Sciences and is a distinguished fellow of the AAPA. And finally, Dr. David Malebranche is an internal medicine physician and former associate professor of medicine at Morehouse School of Medicine and Emory University School of Medicine in Atlanta, Georgia. We are thrilled to have this group of clinicians and educators with us today to talk to you about how to integrate case studies into your online and physical classrooms and how to incorporate both clinical and bedside manner skills into your teaching. During today's webinar, Dr. Wijesinghe will give a brief background on why he created this book, along with an explanation of the general organization and rationale behind the content. Our main focus will be a review of a sample case with the panelists, incorporating a little audience participation, followed by some concrete teaching strategies for incorporating case studies into your courses. At the end of this presentation, you will have the opportunity to participate in a survey about this webinar and request sample content from this book for your review. The presenters will be happy to answer any questions you have at the end of this presentation, but you can submit your questions at any time by clicking on the Q&A button at the bottom of your screen. Please welcome Drs. Wijesinghe, Harry Kwan, Layla Shore, and Malebranche.
Good morning or good afternoon, everyone. First of all, thank you, Springer Publishing, Suzanne Toppy and her team for organizing this webinar. So what is the origin of this publication? As a PA student, I really enjoyed learning from real case studies. As a PA educator, I realized when I used real cases, students were motivated to learn. With that background, I wanted to publish a book with real cases. My initial idea was to write a book focusing on clinical skills. Then meeting Dr. Alex Moyer and working with him inspired me to focus on bedside skills. I met Dr. Moyer when I was a new PA. He was my supervisor and mentor. He was outstanding in both competent and compassionate care. As I worked with Dr. Moyer, I realized my compassionate skills were enhanced and expanded. Current literature confirmed that compassion is a teachable skill as well. I was committed to share this powerful message with other clinicians, mainly with future clinicians, by keeping compassionate as another key focus of this book. 101 Primary Care Case Studies is my opportunity to do that. So what is the focus of this book? In addition to clinical and bedside skills, I really wanted to focus on primary care medicine. I firmly believe primary care foundation is vital for any clinician. Then I wanted to provide an opportunity to PA, NP, and medical students to learn independently or as a group. Furthermore, I wanted to demonstrate collaboration among our professions. That is, significance of teamwork. Now let me share a little bit about our team. During this publication, I reach out to physicians, NPs, and PAs who are passionate about sharing my vision. That's promoting clinical and bedside skills through real patient cases. It is important to note that the book includes real cases, but we have altered demographics and personal information to protect patients' privacy. This book includes more than 50 contributors and more than 30 reviewers nationwide. They are NPs, PAs, and physicians. Today, I am very fortunate to have three contributors with me during this webinar. One is a physician, Dr. Malabranch, one is an NP, Dr. Harry Kwan, and one is a PA, Dr. Leela. We have tried our best to simulate primary care clinic during this book. Case presentation is exactly similar to what happens in primary care clinic. The case includes the following information. Patient comes to your clinic with the chief complaint, then PCP obtained the history, that is history of present illness, HPI, then review of systems, and then it has the relevant history, including medical, social, and family history. Then we have listed allergies and medications. Then we provide a physical exam. This is exactly what took place with this patient in real life. And after presenting all this information, we really like to challenge students with questions. Each case will have 11 to 13 questions to stimulate critical thinking. The questions are related to both clinical and bedside skills. Now we are going to talk about these questions and why we included them. Dr. Malabranch, would you please talk about those two highlighted questions?
Yes, absolutely. And I want to just thank you for pulling this together and inviting me to be a part of this. It's just been an amazing experience. And when we're talking about clinical discussion questions, we look at the 5 bullet points here, but I want to really hone down for sake of time on the last 2, which we're talking about, should tests or imaging studies be ordered, which ones and why? And what we were focusing on with these cases is encouraging the students to actually think through these things. So when someone presents with a certain HPI or a certain clinical syndrome or gives you a certain history and you combine that with their physical exam findings, going through a differential of what kind of tests are going to be the best tests to order exactly to figure out what the disease process is and why you're doing this is particularly important. Not only predominantly for patient care or for the priority of patient care and making sure you confirm the diagnosis that you suspect from a history and physical, and then can move forward with the management, but also in today's medical system where a lot of things are about cost cutting and making sure that you're saving money, and some places don't have the resources as others. You want to be very intentional about what tests you order and exactly why. And if you have to think through these things, we try to get the students to think, if you are ordering a test, there has to be a reason. Is it going to change your management? Is it going to lead you down a path where you're going to figure out and confirm or either exclude a certain diagnosis? So that was particularly important. And then finally, what's the next appropriate step in management? So for a lot of these cases that are included in the book, and the one you'll see today, we're talking a lot about when you get all this information and you finally get the test, what are you going to do then? Is it something you can handle on your own? Is it something you can manage as an outpatient? Is it something that needs a further consultation with a specialist? Or is it someone that may need to go to the emergency room? So I think we were very intentional with these discussion questions to really make sure we were getting students to think through, not just regurgitate acronyms and things like that so they could kind of spit out what is seen in the book, but actually think through the processes as they're moving a patient along to getting them to a more healthy state.
Thank you very much. Dr. Harry Kwan, would you please talk about these two highlighted questions and the rationale?
Absolutely, happy to be here. All of the discussion questions on this page are very pertinent to every case study, but in particular are the coding requirements for a particular visit. I think that this is one of the most difficult things for my students to comprehend is what to code and how to code it. And so the case studies in our book actually give students the opportunity to practice coding. And while we all may have coders that can offer education at our organizations, having the students prepared even in a small way to select the correct code is going to be a big benefit for them when they enter practice. The other part of this particular screen is the education that patients will need. I think one of the things that patients value the most from us as providers is the education that we give them about their particular problem. And it is also something that is critical for us to take forward and give to our students, that they need to understand the importance of selecting the correct education to give to the patient. Patients will follow what we ask them to do more often than not. But if we don't tell them what we need them to do, they're not going to do it. So patients need the education, and students need to understand what to share with the particular patients and for their particular topics.
Great, thank you. As I mentioned earlier, teaching bedside skill is a primary focus of this book. Each case will have 1 to 3 questions regarding bedside skills. Dr. Lilesha, would you share these questions, please?
So one of the most exciting things about this publication, I believe, is the fact that there is a focus on just compassion, as Dr. Wijesinghe mentioned earlier. And we can teach this. In fact, most of our students come in with this. This is why they come into healthcare professions, but they forget. We almost train it out of them to a point, learning all the medicine. In this book, they'll be reminded that the patient is a whole human being and that there are things about the patient's world that they need to learn and they need to approach in maybe a different way. So what style would be appropriate to an individual patient will change case to case across the lifespan, and depending on any cultural factors of importance. And then if there's distress for the patient, the reassurance you provide is not that everything will be all right. It's that you are there to take care of them and to guide them through this, you and your team.
Great. Thank you very much. So this is how the actual book looks like. This is a picture taken from the book. As you can see, there is a space to write answers to each question. Remember, this is a workbook for students, and they are expected to write answers to all these questions or as many questions as possible without looking at the answer key. So let's talk about the answer key a little bit. We decided to include the answer key online. So why we decided online? We surveyed PAs and NP instructors from programs nationwide to determine where best to supply answers. Should we provide the answers only to instructors or make answers accessible to students in some way, either in the book or online? The majority of instructors told us that students at this level need to engage in independent learning. Providing answers online is just enough friction to encourage students to first try to answer the questions themselves, but also provides the support they need for independent learning and discovery. Now we are going to talk about a sample case from the book. So the chief complaint, I have fever and back pain. She's a 78-year-old woman, and she has 2-day history of fatigue, malaise, and fever. And she's getting worse, and she has a right mid-back pain and nausea. She's getting worse, and resting and taking Tylenol is helping her a little bit. She described her pain as 3 or 4 out of 10 scale. She did receive the flu vaccine about 3 weeks ago. She lives by herself, and she's afraid of becoming seriously ill and having no way to call for help.
The review of systems for this particular patient are positive for occasional knee pain. She has no weakness, weight loss, or any other focal pain besides that right flank. No problems with her memory, concentration, and also no recent illness or injury. Her relevant history really is only significant for hypertension and osteoporosis, and fortunately, her daughter lives nearby, so can help out as needed. There's no allergies to medications, the environment, or food. And her medications are primarily meds that she takes just for hypertension and for osteoporosis.
On our physical exam, you find that her temperature is 38.8 Celsius or 101.8 Fahrenheit. In general, she appears ill and uncomfortable, but non-toxic and with no acute distress. You notice that her skin is pale and she's slightly flushed. And her abdomen, these are all the pertinent positives we're talking about. There's mild right CVA tenderness, and She also has mild suprapubic discomfort, but no tenderness down there. For the genital and rectal exam that you do, she has vaginal and intraoral mucosa show atrophy in both those areas. So that's your physical exam.
Now we are going to talk about the online answer key. We provide answers to all the questions in the answer key, but during this webinar, we will be talking only a few answers. So think about the sample case for a moment. And I want your participation here a little bit. So think about this sample case for a moment. Based on the information given, this is the differential diagnosis list. I just want to remind you that this was the differential diagnosis came up with the primary care provider when she was actually dealing with this real case. So influenza, pyelonephritis, osteomyelitis, metastatic cancer, and endocarditis. Now let's make this webinar a little bit more interactive to find out what is the most likely diagnosis. Can you please provide your answer? You can pick your answer choice. Is the poll working fine? I think I'm going to give you like 10 more seconds. All right, let's see the answers. All right, wow, this is very impressive. Pyelonephritis, we have almost 75% have got the answer right. That is excellent. So let's go to the next slide here. So this is an example of how the answer key looks like. The answer to this question is pyelonephritis, as most of you guessed. The PCP has provided the rationale why it is the most likely diagnosis here. You will be able to see that. And in addition, PCP has provided why the other diagnosis in the list is not the most likely diagnosis. We thought that's important to provide that information. Sometimes our students are doing a really good job coming up with the differential diagnosis list, but sometimes it's hard for them to understand why some of them are not the most likely diagnosis. So we decided to provide all that information with their answers. Dr. Malabranchi, so actually I just want to add something here. Now we have formulated the differential diagnosis list and then the most likely diagnosis. So what is next? Dr. Malabranchi, could you share what kind of tests are helpful to further evaluate this patient and what will be the next step?
Yeah, so for this case, you received some more answers. I mean, obviously 3 out of 4 of folks who are answering now thought it was pyelonephritis. Your test imaging, the UA showed some leukocytes, trace blood, and positive nitrite, and the urine was sent for culture and sensitivity. Obviously, you're not going to be able to get culture and sensitivity immediately. It may take a few days. So as a clinician, you're going to be asked to do something at that time. So with regard to next steps for this case, she was started on empiric antimicrobial therapy, ciprofloxacin, 500 milligrams BID for 7 days, and instructed they were going to monitor the patient closely over the next day or two. You call the patient the next day to assess them. Patient states that it's getting worse, including fever and nausea. So obviously that's an indication with the nausea, they may not be able to take the pills that you gave them. So because she lived alone and was showing worsening symptoms suggestive of impending sepsis, which was the nausea combined with everything else, she was hospitalized.
Couple of unique features of this book is that discussing real outcome of the actual case and the insight from the primary care provider when managing this patient. Dr. Leelasha, could you please share this?
So for this patient, this was actually my patient. And the flow was, of course, it was pretty obviously pyelonephritis. The concern was because of her age and because of the nausea, how serious was this? But her daughter agreed to stay with her outpatient. and she was left for one day with a phone call the following day, at which point, because she was worsening, she was hospitalized and put on IV medication. When the culture did come back, the medication was shown to be effective, and it also gave us an outpatient medication, an oral medication that would be a step down. So trimethoprim sulfa was able to function for this patient outpatient. But in terms of follow-up, she became very fearful of having pyelonephritis again. And as noted on her physical exam, she had some vaginal atrophy that caused her to be mildly symptomatic with urinary symptoms from time to time. So over time, monitoring this, it was decided that because her breast cancer risk was low, that we could treat her with vaginal estrogen tablets, and that would reduce her symptoms. So the importance of the whole body care for this patient following her illness was really important, not only to her physical health, but also to her emotional health. She became more attached to her community, and her daughter kept closer tabs on her after this, which was very important for her as time went on.
Due to limited time we are not talking about answers to pathophysiology, literature review, ICD-10, patient education, legal concerns, and interprofessional collaboration, but it's all on the answer key. After having some brainstorming, we decided to organize the book by chief complaint, not by the diagnosis. This is just like primary care clinic. Susan, would you please share a little bit more information about this?
Sure. Because the table of contents is organized by chief complaint, we anticipated that instructors will need a more direct way to find cases that fit their lesson planning needs. And so for that reason, we created a filterable table of contents for instructors who adopt the book, which allows you to sort by diagnosis, body system, patient age group, and patient gender, so that you can find exactly what it is that you need to assist you with your lesson planning.
So, why are we having this webinar today? That is to talk about case study teaching strategies. As you all know, writing a good case study is difficult and also time consuming. Having more than 100 real cases will be very helpful for any program. Also, these are real cases written by actual primary care providers. So, what are some high points? It's versatile and adaptable, able to use in any NP, PA, or medical programs, able to use in traditional or online, and also you'll be able to use during didactic or clinical phases, and then it will provide both independent or group learning. Let's talk about some assignment ideas. You will be able to take any case from the book and make it a graded or ungraded assignment. Students will be able to complete the assignment individually or as a small group. Each case is long enough, so a small group is an effective way to teach. I recommend about 3 to 4 students in a group. It can be done in classroom or online. If you do it online, let's say you are using Zoom, you will be able to use breakout method for small group teaching. These cases are really helpful for SOAP notes teaching as well. Case already has the subjective and objective part. Students need to summarize the highlights from the case and complete the subjective and objective parts, then complete the entire case and come up with the assessment and plan. So now they have a SOAP note. So this can be graded or ungraded. After completing SOAP, student can present the case to the instructors or to the entire class. And this is an excellent preparation prior to starting their clinical rotations. Dr. Leelasha, you have been in PA education over 30 years. Anything you like to add as far as SOAP notes teaching?
Well, I think you've hit it. The big thing is the critical clinical thought process And one of the things students have the hardest time is focus, focus, focus without putting blinders on and narrowing their differentials. So what is the clear thought process? And that's described in the SOAP note. So when they get to their assessment, they should be able to clearly delineate, you know, as we do in the book in the answer key, the differential diagnosis and why this is more or less likely, and what they're going to do next based on that. And that's the assessment and plan piece. This is a service to our students, but also to our preceptors, because more and more our students are coming in and having a hard time with that piece. The more skills we can give them going out into their clinical rotations, the better for all concerned.
Thank you, Dr. Leelasha. Actually, I like to add one more thing to that. You know, I have been a preceptor for 7 years, and when students come with the SOAP notes, you know, preparation, that actually help us quite a bit, you know, as a preceptor. So, you know, this book is an opportunity to teach good SOAP notes to your students. So, objective structured clinical examination, known as OSCE. This is a practical way to test students' knowledge and preparation during didactic, prior to clinical, or during clinical. OSCE is a great way to challenge your students. Let me share some ideas. You may pick one case study and assign for every student. This is a great way to identify students who might be struggling in the program. You may assign a case from the entire workbook, and then this is a substantial commitment from the students because they need to be ready for more than 100 cases. You know, that's a substantial commitment, but you have the option to do that. You may notify students to prepare for 10 to 20 cases and then assign a case from the list. This is a moderate commitment from the students. Or you may notify students to prepare for about 5 cases and then assign a case from the list. This is a mild commitment from the students. Dr. Malebranche, you have been teaching at medical schools for many years. Can you share some information about OSCE?
Yeah, I think that, you know, OSCE, a lot of medical schools obviously use this tool to get students to enhance their clinical skills. And I think, as we were mentioning earlier, you kind of want to get students in a formality where they're actually thinking about a broader differential diagnosis. And I think in these days and times, a lot of students may look at residents or their attendings or their supervisors who make a beeline and go straight for the diagnosis immediately. And we don't want to encourage that, because when you're a student, you have more time and you're actually available to formulate this differential diagnosis. So I think, you know, when you have an OSCE setup, the book is very capable of being fit into that, that structure where you have students or paid actors. They can act as the patient. You debrief immediately after the session, or you can debrief later after the recording sessions. And for instance, at Morehouse School of Medicine, we used to watch them right outside in monitors, visualize what they were doing as they went through the whole history and physical exam. And we used paid actors in our OSCEs. But they kind of go through this thing, and then we come in later on, talk to the patient, and then talk to them about how they all felt about the encounter. And so it can be either synchronous or asynchronous learning. And what that means is that for synchronous, you know, a student can work on a case and present to the class, and others can watch live, which is synchronous, or later, which is asynchronous. And the student, or whoever is the clinician at that point, and the instructor or the patient can work on the case, and the instructor evaluates either synchronous or asynchronously later. But I think as far as all these cases, and when you have 101 patient cases like this, it really gives a good template and a good foundation for the breadth of cases and clinical presentations that a lot of students will see once they get out of school.
Excellent, thank you so much. Dr. Harry Kwan, how can this book be helpful, particularly with current situation that we are facing for online and interactive learning?
COVID-19 has challenged all of us in both academia as well as clinical settings to find ways to get our students prepared to take care of patients. And after the pause of several months, all of us have gotten back to getting our students back into clinic, whether it's virtually or in person for the rare days that we're actually on campus or in clinic. So this book is a great way for the students to prepare for patients that are going to be seen, because these are all primary care cases. I've thumbed through the all of the topics and said, oh yeah, at least 20 times I've seen this particular type of case, and go through that with your preceptees and prepare them for how they might consider caring for that patient. So an example might be for my students that come into clinic with me, give them one particular case and ask them to think about that particular case, and then come back to clinic and walk through their thought process. It doesn't matter to me whether they spend time on Google, go into their books, or any other source, like Hippocrates, to find information. I want them to really think strategically as well as deeply about the cases while they're students, because this is a great opportunity for them to go deep. And this book is an excellent learning tool, because we went deep with every case to give the students preparation so they could be ready for these cases when they see them in clinic. Dr. Malebranche already talked about the synchronous and asynchronous opportunities with this particular book. The education that we're offering our students happens very often asynchronously. We obviously have them attend lectures in a synchronous manner, and then asynchronously assign them different projects to do, whether individually or as a group. So as mentioned before, you could actually prepare the students by having them deeply review 5, 10, 20 cases, and then during a synchronous session, have them actively talk about the case and how they would actually care for the patient. So that's one example of a way that this book could be used synchronously and asynchronously at the same time. It really does help the students think about the disease process and what they might do to treat this particular patient. It really doesn't matter if they choose a differential and then back it up, because we've got the information in the book. So you can actually go through that with the student and talk to them about why our last case example wasn't osteomyelitis, for instance. And that is a great learning opportunity for our students, because they may be okay pulling up differentials, but they may not be able to think through why isn't it this particular disease or that particular disease. I've seen that a lot with my new students, and as they become more thoughtful in their process in working through the disease, they're able to select the correct one more often than not. So great book to guide you as you precept your students in clinic, whether virtually or in person.
Excellent, thank you. This book can be a resource for preceptors during clinical rotations as well. As I mentioned earlier, I have been a clinical preceptor for 7 years. With my experience, let me suggest an idea. Preceptors will be able to choose a case that student has not experienced during a rotation or has seen only a few cases. For example, let's say that you are a preceptor and you have a student for a month. During that time, student hasn't seen a pyelonephritis case. Then you may use that case from the book and then teach the student about how you're going to manage a patient with pyelonephritis. So I encourage programs to consider this book as a practical resource for their preceptors. Working with many clinicians and getting to know them closely was a great highlight for me as the editor of this book. I am very honored to be here with 3 contributors today. I am well aware that they all have done some remarkable work as clinicians and medical educators. Would you share a highlight that you experienced during this publication? Let's start with Dr. Harry Kwan.
Absolutely. I loved the idea, the concept of this book from the very first time that I learned about it. As a preceptor, I've been a preceptor for 15 years. I really don't have any resources like this book to share with my students. I just have patience. And having the opportunity to work with the type of collaboration that I actually have in clinic, my PAs, my physicians, and NPs, this was really more like real life than any book that I've actually used with my students.
Dr. Lilashe?
I would totally agree. I love the interprofessional aspect of this. And as a preceptor, I right now miss my team room with the NP and the MD and the medical assistant and the lab tech all sitting in the same room. But we still operate as a team, even in this virtual reality. But more of my work in education has been on the didactic side. And as we said earlier, boy, is it hard to write a good case, and how nice to have a batch of 100 wonderful cases all set and they're real.
And Dr. Malabranch?
Yeah, I would echo all the things that have been previously said, but Dr. Wijesinghe, you were a taskmaster with this, which was amazing and a great experience. Even though I probably was cursing you out sometimes behind my computer at some points. But I think what people need to know about this book is that there's a certain level of rigor that is expected and that you expected of us as we wrote these cases, which were based on real patients, but again, de-identified, so as not to break any HIPAA laws. But I think what was great was the collaborations between physician assistants, nurse practitioners, MDs, and instead of us existing in silos or being pushed against each other, in a space where we have to be competing against each other, it was a much more collaborative and thorough process, and all to benefit the students. And for me, I just recertified for my board exam in internal medicine about a year ago. And what I like about, the format and kind of how this is presented is how there is an explanation. You give the differential diagnosis, but then you also explain why the differential diagnoses are not the best answer, in addition to why the correct diagnosis is the best answer. And that mimics a lot of the board examinations that we have to take and that we have to think through. And for me, part of the learning process is always, when you get it wrong, you have to understand why you get it wrong and why you miscalculated on a certain thing, or what red herring you went for in the physical exam or the lab test that actually didn't lead you to the correct diagnosis. So I think it was very intentional on your part, and I'm thankful to be a part of that rigor with making these cases, because a lot of work went into them, and they do kind of mimic what you see on a lot of the board certification. And the goal in these days is not always to get the highest score or to perform the best on the test. Obviously, you need to get a passing score to be certified, whether you're a nurse practitioner, physician assistant, or an MD. But we really wanted to emphasize the thought process. The way you make good clinicians is to get them to think through it. I said this before, but you don't want people just memorizing stuff and regurgitating it. Anybody can do that. We want you to think through what a patient gives you and what they're presenting in front of you. Treat them as a whole person and work through making the correct diagnosis. As students, they have to understand that you won't get it right all the time. As faculty, we don't get it right all the time, but it is part of the process, and that's how you learn and become a better clinician. And I think this book really takes a good step in making that happen.
Thank you very much. So to summarize, PCPs have the opportunity to provide competent care, also known as evidence-based medicine, and compassionate care, also known as art of medicine. 101 primary care case studies were initiated both those things in mind. Practicing clinicians, medical educators, and future clinicians should be intentional about both these notions and do our part when delivering patient care and teaching our students. I and my team are hopeful 101 primary care cases will play a role in many clinicians' lives who are aspired to become not only competent, but also compassionate. Thank you very much for your participation.
So now we're going to open up the presentation to some questions from the participants, and it looks like we have a few. And panelists, please just jump in if you feel like you would like to answer the question yourself. So the first question is, can you elaborate on how to use this book as a remediation tool for struggling students?
I think I can address that. I am in charge of a lot of the remediation for our program. And one of the most important areas where students struggle is that clinical reasoning part that Dr. Mallingrad spoke to so succinctly, but getting them to just do it over and over again. So assigning several of these cases with more complex differential diagnoses and having the student work through is a really good way to do that. Now, there's several platforms online, but they all have problems. I think this workbook format just really forces them to do that, and then you can go through it with them, see how they're doing, and these are things they can learn.
Thank you.
Can I just add on to that? I just want to speak as someone who actually struggled in medical school, and I almost failed out after the end of my first year. I wish I had had something like this because it would have been very helpful. You know, sometimes with all the volume of information we have to take in as students, it gets to be overwhelming. And if your focus is not there, or if life happens, you can really have trouble with this. So I just want to emphasize, you know, that it is important to have this, you know, when we're dealing with students who may have to remediate or may be struggling and you have to get them back on track, that this kind of helps with the overall picture of helping them to get to be better clinicians. And obviously I made it through after struggling because I'm here talking on this webinar right now.
I can add on to that as well. I want to also point out that all of us are adult learners and we all learn in different ways. And when I first got case studies presented to me, it was amazing the difference my brain was able to take the information in a very different way and make sense of the disease. So I see diseases differently than I see diseases in a book. And having the case study available to walk through was very helpful for me, that whole concept of how a case study is set up. So I sought out lectures that presented the material in case study format because it was incredibly valuable. So this is a resource that we didn't have available when I was in school.
And so I'm going to actually answer the next question. So somebody's asking from the audience, what are some additional examples of how compassionate care is incorporated into this publication? So two unique features of this book, a real outcome of the case and then the insight from the primary care provider. So when I was reaching out to potential contributors, one of the questions I asked them, think about a case that already in your heart, you know, you always run into these cases that you will never forget. And so most of the cases that we have selected, they remember this case very well. And because there was something very special about all these cases. And then, you know, when providers talk about the insight from the primary care provider, they talk about the compassionate part on every single case. So so that is how we are trying to encourage, you know, students to, you know, read that insight from the primary care provider piece, and then, you know, that I think that will be a really good learning opportunity for students. Then we have another question. Can this book be utilized for a new grad to the primary care arena? And Dr. Leelasher, any thoughts on that?
I think absolutely. So one of the things new graduates struggle with is you know, a second round of imposter syndrome. If they didn't have it when they entered their medical education, they now feel totally unprepared to actually enter the workforce. And if they don't, you actually kind of worry about that. Going through some of these cases can help them to feel more ready For example, I have some students, particularly this year, the last portion of their clinical rotations was shaved off by COVID. And so they maybe didn't get a very complete emergency medicine rotation or primary care rotation. And so utilizing these cases is a way not only to work that medical clinical reasoning, but also to assure them that they do actually know what they're doing.
I might comment as well that I did a lot of work studying the transition shock that new grads have when they enter the workforce. And having a trusted resource to go to, like a mentor, and a well-researched book to use when you have questions is invaluable. So something like this book could absolutely be a great supportive tool for a new grad coming into primary care.
Dr. Malabrach?
You know, I didn't want to be too long and add on to what already has been wonderfully spoken. I will say, just to add on, is that I think that for new graduates particularly, I think when we talk about imposter syndrome, it does happen. And imposter syndrome actually doesn't go away with a lot of us after you first start practicing. There are moments where it may peek its head back in as you get to certain peaks and valleys in your career. But I do think one of the main things to emphasize is that the best way to learn material is to be forced to teach it. So while this book is meant for students and helping students learn, I do think for a lot of faculty in all our clinical professional skills and clinical professional schools, we can actually benefit from this, because as we review this stuff and we have to teach it to other people, it will help cement those things in our minds so that we can be not only better clinicians, but also better teachers.
Thank you, thank you. And so now we have another question from the audience. Do the cases vary in level of difficulty? And is this noted somehow? So, one of the things that I did initially to select the topics, I actually took Pan's blueprint as a guide, and I wanted to make sure that we cover most common diagnosis in primary care world. And then, so I was trying to do two things at the same time. One is to try to decide topics from the Pan's blueprint. I know Pan's blueprint is universal. It can, NP world, medical world, they all will be able to, they are using very similar models as far as, this choosing diagnosis. So, so I wanted to use that list and also, ask the providers what might be a case that you will remember and you want to write about. So the cases are from the, so these cases are all in, very, very commonly we see in primary care medicine. So there is no really difficulty. You cannot really say what is difficult, what is not difficult. But what I can say is that I have invited some very experienced providers. Some of them, they were actually my mentors and some educators that taught me when I was a PhD student. And then some of the contributors I invited, they were my students. And so you will be able to see a variation, and it's a very good mixture of cases. That is very intentional. Medicine can be very, it can be very subjective. We might come from different angles, but ultimately come to the same most likely diagnosis. So it's all there in these cases, very good mixture of cases.
Dr. Wijesinghe, can I add something on to what you just said? I think it's a good point to make, that it's not necessarily about a more difficult case or a more complex case, but especially in primary care, we see things and we tend to go straight to the most common diagnosis. And I think what we have to really emphasize, and what this book really emphasized, and I'll give you an example. Dr. Wijesinghe asked me to do a case presentation on urethritis, right? So a lot of times when people think about urethritis, they think about gonorrhea and chlamydia. But there's also other things you need to think about, whether it's kidney stones, could it be an allergic reaction, or there are other non-gonococcal bacterial infections like mycoplasma, ureaplasma. And these are the things you don't see as commonly. And what you did in pushing me with this book in these cases is to explain those things. So instead of making it saying whether one case is difficult or not, we want people to think thoroughly about all of these and not just go with the most common diagnosis, but think about some of these other things that you could miss. And then what happens if you treat a patient initially for what you presume is the most common diagnosis, and then they come back and they're not improved? What do you do then? And so these are kind of real life experiences. And I think we were very intentional with challenging ourselves to go to cases where it did present not just always the most straightforward beeline to that one diagnosis, but something that may challenge you a little bit or ask you to question a few things here or there. So I think, as far as difficulty, anything is going to be difficult, but I think it forces you to think a lot more thoroughly and consider some of the different differential diagnoses than maybe you didn't consider in the past, or that other modes wouldn't actually teach you.
Yeah, and I do want to say that one of my preceptors, when I was a student nurse practitioner, used to say to me, when you hear hoofbeats, are you thinking about the horses? Are you thinking about the zebras? Because I definitely had some zebras, but they weren't on my differential list. So it was a learning for me that you've got to include everything, because when you're working up that patient, that's all got to be in the back of your mind.
And next question, I will actually have Dr. Malebranche answer this. Would this be a good prep resource for USMLE 2 or USMLE 3?
It probably will be for both, to be honest with you. I think you're starting to get a lot more clinical cases that are integrative in USMLE 1 and then also USMLE 3. I think it can be a good adjunct and keep you training as you're going along through it. Obviously, and I'm one of those people, to be honest, I talked about how I struggled through some of the medical school thing, and I'm not the best standardized test taker. So I'm always a big proponent of doing standardized test questions that are at the level of the standardized test that you're going to be taking. These cases will approximate the level, but they may not be worded in the exact same way. So I would say you can do both. So I say it's a good adjunct with that as well. So as you're preparing for cases, remember to think about it this way too. It's not just that you want to score well on these tests. You do have to score well on these tests and pass them to get your certification and move on. But the bigger picture is that you want to be a good clinician. And I can be very, very honest with you that some of the best test takers that do the best on these exams are not the best clinicians. So I want to encourage people to use this book as a striving tool so that you can be both, not just a good test taker, but a good clinician overall. And I think you can do both. It's not an either or scenario. So use the test books that are specific and the practice questions for USMLE 1 or 3 or 2 in that case. And then also make sure you're complementing it with this, because I think these cases that are in here are real life. And everyone will tell you, I'm sure all the other co-panelists will say this, a lot of the correct answers that are in some of these practice exams and these certification exams are not reflective of what you do in clinical practice and may not be up to date with what the clinical guidelines are. So you have to be careful. So use both of them.
Great. So there is another question. Does the book include some psychiatric problems? This is, the cases that we see in primary care. To answer your question, yes, we have some psychiatric problems. And again, we are very intentional about that too. You will be able to see all the organ systems, cardiology, pulmonary, dermatology, orthopedics, and psychiatry. So you will be able to see a very good mixture from all the different organ systems. There is a question here. Susan, maybe you might be able to answer this one. Susan Toppy.
Sure, yes. The question is, will there be a reduced purchase price for attendees? So the book is not yet published. It publishes in November. You can pre-order it on Amazon. However, if you'd like to wait to order it from us at a discount, we will be sending out a coupon code after the webinar, along with a recording of the presentation. to all participants. So be on the lookout for that. And when the book is available for purchase on our website, you will be able to use that coupon code.
Great, thank you.
And that looks like the end of the Q&A session. So thank you all for your questions. We've reached the end of our webinar, and I'd like to take a moment to thank our panelists for their presentation and all of you in attendance for your participation. For those of you who are interested in requesting sample content to review for your courses, you'll have the opportunity to do so when filling out the post-webinar survey. The slide that's up on your screen also gives you instructions on how to view that sample content and how to find your sales representative for your region. On the survey, simply answer yes to the question about receiving sample content. You can also visit springerpub.com/instructors for your regional sales manager information. This webinar has been recorded and will be shared with all participants in about 7 days, and will also be posted on our website under the video section for future reference. I hope you all have a wonderful day.
Thank you, everyone.
Thank you.
All right, thank you.
Thanks. Bye, everybody.
All right, bye.